So high-grade spondylolisthesis is a difficult problem. Any surgery can be quite challenging. It's often difficult to place instrumentation, but the aim should always be the same, whatever surgical procedure you elect to undertake eventually. That is to achieve a solid fusion, relieve any neurological symptoms that the patient may have, and try to restore alignment and balance if you're able. A big problem with the very high-grade dysplastic type of spondylolisthesis is that the sacral anatomy and that of the lumbar L5 vertebrae is often distorted. There's sometimes significant rounding off of the sacrum and sometimes wedge-shaped deformity of the L5 vertebra, along with the well-known kyphosis angle of the lumbosacral junction. And that makes the pelvic parameters difficult to measure. Whether or not that's important is perhaps a moot point, but you've had a very good overview of how to measure the pelvic parameters just recently. But the surgical options, I think, can be broadly put into four groups. There's the non-instrumented fusions that are usually in situ. There's instrumented fusions by a posterior approach only, and that may be something fairly familiar, like a posterior lumbar interbody fusion or a TLIF. There's the delta fixation with transdiscal screws going from S1 up into the L5 vertebral body across the disc space. And there's the strut grafts, which can be placed either anteriorly or posteriorly. The Bowman procedure is where where a strut graft is placed from S1 across the L5 disc space into L5, and the so-called reverse Bowman is an anterior approach where the graft is driven from L5 into the sacrum, usually combined with posterior fixation as well. And then there's the Gaines procedure, which deserves mention, but it's used by a very select number of surgeons, and I've got no experience in utilizing that in the management of high-grade spondylolisthesis. So the uninstrumented fusion techniques are worth mentioning. The technique is a posterior midline skin incision and then a bilateral Wiltse incision through the fascia to get to the facet joints and the lateral gutters on both sides. Then a placement of usually iliac crest autologous graft, both posteriorly, morselized posteriorly, and a structural, usually tricortical graft placed into the disc space through an anterior approach. The Finnish group are probably the leading exponents of this and have reported excellent results. As you can see, solid fusion here, and the long-term functional results are also excellent. So this is not solely a high-grade paper, but 21 years after a posterolateral fusion only, they report very good long-term results, regardless of whether there's pseudarthrosis in that series. Moving to the instrumented techniques, the PLIF and TLIF are very familiar to most spinal surgeons. I use long tab screws or reduction instruments to pull L5 back, and disc space preparation also helps the reduction. And you can use the disc space reamers that are on most sets as levers to try and help do the reduction as you're pulling on the screws to reduce them to the rod. My personal preference is to do a PLIF rather than a T-lift, because I feel that you get bigger graft area and more secure cage placement. And it's often better to instrument a little bit longer than just one segment, especially if there's, especially if you're worried that the L5 pedicle or S1 pedicle screws will have a lot of force applied to them. So here's a case of mine where there's significant high-grade dysplastic spondylolisthesis with sacral rounding and wedge of the L5, as we've said, in a young athlete, and intraoperative pictures that show my placement of the screws and reduction or partial reduction, not going for full reduction, using the disc space instruments to help reduce the slip, as well as to prepare the L5-S1 disc space. And my aim in this case was not to fuse the L4-5 segment, but I will come back at a later date and remobilize that by removing the L4 screws and shortening the rod once I'm sure that the L5-S1 segment is solidly fused. Delta fixation, again, is familiar instrumentation to most surgeons. The S1 entry point is the same as for a standard S1 pedicle screw, but you have to make sure that you can get a trajectory through the disc and into the L5 vertebral body. It affords a good 3-column fixation and can be good for high-grade slips, even though it was initially described for low-grade spondylolisthesis. My feeling is that it is especially good if the disc space is very narrow and is expected to fuse spontaneously once stabilized. The strut graft techniques, the Bolman technique, if you do it through an anterior approach known as a reverse Bolman, I feel that I think that's very good for high-grade slips with a very high sacral slope, where the natural angle of attack lends itself to placement of the graft and the reamers through the L5 vertebral body and then into the S1 vertebral body. I think it's also quite a good technique to reserve for revision surgery, which has failed, where the anterior approach hasn't been previously used. And you can choose whether to use threaded cages, a fibular strut, or a mesh cage filled with morselized bone. It's really a matter of choice on what's available. Sometimes the entry space, the entry point has to be through the L4-5 disc, in which case you have to fuse the L4-5 segment as well, of course. If you can do a strut graft through an all posterior approach known as a modified Bolman approach, of course that avoids an additional anterior surgery, but does require a more extensive laminectomy of the sacrum and manipulation of the dura in order to place the reamers and the eventual strut, this time from S1 body across the disc and into L5. This paper illustrates the different angle of attack of the anterior reverse Bolman on the top level here, with the reamers going through L5 into the body of S1, and on the lower part of the slide, section B, where the reamers, as you can see here, move from the S1 and across the disc space into L5, but the principle is the same. This is a case that I performed and was referred to me as from another hospital with failure of the instrumentation, which was just a posterior and posterolateral fusion, but unfortunately went on to pseudarthrosis with fracture of the S1 screws here, as you can see, and a non-union of the L5-S1 segment. So we chose to perform revision of the posterior instrumentation and extension up one level, and then anterior interbody fusion with threaded cages at L3-4 and L4-5, and a threaded cage in a reverse Bolman type anterior approach across the L5-S1 segment, and that went on to fusion, and this is her 6-year follow-up, and fusion is solid and she's doing well. So in summary, there's no one technique that is suitable for all situations, and I think it's important to maintain flexibility in your approach to these cases. It's worth remembering, it's worth saying again, that non-instrumented fusion has given really quite good results. That's worth bearing in mind as well. My personal preference is to use a PLIF approach if I can reduce the L5 reasonably well and get good cages with a reasonable graft area into the disc space there. But if it's very high grade and quite stuck and not very reducible, I do use strut graft, usually from the anterior approach. That's just our method of doing it in our hospital, with which we're most familiar. So that's our preferred approach. But again, that's just a personal opinion. So thank you for that.